Attention women's health professionals, the next round of FAMM is just around the corner. Classes start on October 4th. FAMM is the perfect program for busy women's health professionals who want to offer fertility awareness charting support in their practice. FAMM cuts out all the fluff and only focuses on what you need to serve your clients better. Each module, homework assignment, in-class training, and chart review session is there for a reason. Where will you be 9 months from now? With a FAMM certification, you'll have a brand new skill set that will allow you to use the menstrual cycle as a diagnostic tool and vital sign in your practice. Your confidence in analyzing and interpreting menstrual cycle charts will be at a level you can't even imagine today. And you'll have a brand new offering in your business that will allow you to reach more clients. This knowledge is truly life-changing. Transform your practice in 9 months. You won't regret it. Join us this October in FAMM. Head over to fertilityfriday.com/FAMMlive to apply today. That's fertilityfriday.com/FAMMLIVE. This is the Fertility Friday podcast, episode number 484. All right, today I am sharing a brand new episode in my FAMM Research Series. Today I will be getting into the broader topic is really why so many women struggle to get an accurate diagnosis from their practitioner. But we'll be looking at a specific study that looked at physicians and their knowledge about the PCOS diagnostic criteria. And so we're focusing specifically on PCOS and how these physicians fared on this survey, but I feel like it does give us some insights into the broader issue that women often share when they're accessing care from their providers. So without further ado, let's go ahead and jump right in. So the title of the study that we are going into today is called Gaps in Knowledge Among Physicians Regarding Diagnostic Criteria and Management of Polycystic Ovary Syndrome. And for those of you who want to take a look at the abstract, make sure to head over to the show notes page for today's episode. So that's fertilityfriday.com/484. So you'll find the links and everything there. And so we'll just kind of talk a little bit about the study. I mean, it's fairly straightforward in a way. The end result was 630 surveys completed. And they surveyed, I'm just going to look for it here. They surveyed physicians who are part of the American College of Obstetrics and Gynecology, of gynecologists, it says. So OBGYNs, and they also surveyed the American Society of Reproductive Medicine of reproductive endocrinologists. So they studied OBGYNs and reproductive endocrinologists specifically. And I think this is relevant because obviously OBGYNs and REs for short are highly specialized. So beyond the specialization of your family physician. And so I feel like I'll come back to this point as we get into the details, because we could infer that family physicians would potentially be less likely to have specialized knowledge about PCOS. We would actually expect these physicians, specifically who they surveyed, we would expect them to actually have a much higher level of knowledge about this condition. At least I would expect that. All right. And I'm sure you can see the foreshadowing here of where I'm going with this. The general result of the study, I mean, we'll get into some of the details, but one finding that was particularly concerning, I would say, was the percentage of doctors who actually were not clear on which criteria that they used to diagnose PCOS. So I'm just going to read from their conclusion. It says, in the largest survey of North American physicians conducted to understand alignment of physician practice patterns with current guidelines related to PCOS, our study identified that a large percentage of respondents were unaware of the currently recommended criteria for diagnosis of PCOS, with only 68% of reproductive endocrinologists and 41% of OBGYNs applying the Rotterdam Criteria. Okay, so that's me reading from their study. So what does that mean? That means that, I'll just say that again, 68% of the reproductive endocrinologists, so these are highly specialized doctors in reproductive endocrinology, right? Like these are the ones that you go to when you have a problem with your cycle and your fertility and these kinds of things, particularly related to like your endocrine system, right? Like PCOS. And so fully about 30% actually more than 30%, 32% of these reproductive endocrinologists were actually not aware of which criteria that they use. And 60% of the OBGYNs that they surveyed were also not using the Rotterdam criteria. So, I mean, why is this and what does this all mean? So, if you're not as familiar with PCOS, essentially the most common criteria that is recommended and that is used is called the Rotterdam criteria. And so a quick breakdown of that, if you're not aware of it, is essentially there are three main aspects of PCOS that they look at for diagnosis. And if you're following the Rotterdam criteria, if you or your client or patient has two of the three, then they would meet the criteria. So the three criteria, one is oligomenorrhea or anovulation. So essentially delayed ovulation. So we could say it in another way and say long irregular cycles. So this is a situation where a woman has cycles that are longer than 35 days or fewer than 8 periods per year. So she's regularly, consistently having these long cycles, and they're often quite irregular, especially if they vary more than 8 days from cycle to cycle. Okay, so that's criteria one, long irregular cycles. Criteria two is hyperandrogenism, so having excess androgens. And so this can be demonstrated by symptoms. So that could be that you have hair growing in different places that you don't want, hirsutism. So you may be growing hair in your face and chin, back, breasts, lots of different places, but essentially it's just excess hair, and it's often a lot more coarse hair that can cause a significant issue with hair removal, and you can just imagine. And so it can also show up with acne, characteristic of PCOS, like cystic acne. And again, that can be face, it can be back, it can be on the body and things like that. And obviously also a big problem. Not everyone necessarily has those symptoms of the high androgens. It can also be high androgens on lab test, but ultimately that's criteria number two. And then criteria number three is cysts on the ovaries on an ultrasound. And so they have their own kind of more specialized criteria to identify like how many or ovarian volume, like, so a typical PCOS pattern is often referred to as a string of pearls. So if they're looking at the ovary on an ultrasound, they'll see all these little follicles that are underdeveloped. The ovary will likely be larger, so the volume, ovarian volume will be increased. And so, yeah, so they have their criteria for how they look at it. But, you know, just to bring it back, so we've got these three criteria. So we have long irregular cycles, high androgens, and we have cysts on the ovaries, okay? And so a person cannot get a diagnosis of PCOS based on the Rotterdam criteria if they only have one of these. So if you just have irregular cycles, but you don't have the other two criteria, then you wouldn't meet the Rotterdam criteria for PCOS. You wouldn't get, meet the definition and meet what is necessary for the diagnosis. Similarly, if you only have cysts on the ovaries, but you don't have irregular cycles and you don't meet the criteria for the high androgens, then you wouldn't actually meet the definition of PCOS. So that's just a little background, especially if you're not as familiar with the criteria. But going back to the study, what they're saying is that this is the criteria that has been established and widely accepted by most practitioners. There is some debate still. The Androgen Excess and PCOS Society has a slightly different criteria where they require the androgen piece and then one of the other two. So they're saying PCOS is a diagnosis of high androgens, and so you need to have that piece of it. And then we could look at whether or not you have irregular cycles or cysts on the ovaries. But, it's an iteration of the same type of criteria, but ultimately the Rotterdam criteria is more widely accepted. So bringing it back to the study, this essentially means that we have a huge percentage of doctors who are not clear on the most widely accepted and current guidelines for how to diagnose PCOS. And so you may then wonder, well, if this is the case, how does this play out for women? So for those of you who are listening who are practitioners, if you are working with women in the women's health space. So if you are a women's health practitioner of one type or another, then you've likely already seen how this plays out for your clients. And so this plays out in just a number of different ways. One of the ways that I have seen this play out for clients is that you can have clients who actually meet the definition of PCOS. So I've worked with women over the years, many women over the years who meet the definition laid out in the Rotterdam criteria. And so since I'm working primarily with women, be it cycle charting, it's quite easy to see right off the bat if a woman has long, irregular cycles. And so, I've worked with many clients who meet the criteria based on having those characteristic over 35-day cycles, long, irregular, sometimes that have been going on for years and years. And then, when tested, or even from a clinical standpoint, they meet the definition of high androgens. Maybe they've struggled with some of those symptoms of high androgens, or they have high androgens on the test. But the irony is that many of these women who kind of obviously meet these criteria, when we're looking at them from the lens of the menstrual cycle, right, as a diagnostic, if they don't meet the practitioner's idea of what a woman with PCOS looks like, they may not even get screened. So to put that in another way, many practitioners seem to be trained or seem to have a bias where they're anticipating to have a woman, if she has PCOS, to present in a certain way. So they may expect her to appear to be overweight. And I feel like that might be the biggest piece of this puzzle, where they're looking at weight as if it is actually one of the diagnostic criteria when it has nothing to do with the diagnostic criteria. So there obviously is a relationship between the condition of PCOS with some of the other characteristics like insulin resistance, glucose intolerance, and, so some of the more cardiometabolic issues, there's certainly a connection. And so there certainly can be this correlation. There's plenty of women with PCOS do struggle potentially with weight management in one way or another. However, as you can see, it's not part of the diagnostic criteria. So this is one of the ways that it can play out, where you have practitioners who are actually not diagnosing people who have it, and potentially not even screening for that, because they're looking at other factors or other physical characteristics that are actually not related to the diagnosis. So I've seen that happen many times where, again, the woman clearly presents with these symptoms, with, the menstrual cycle irregularities and, the androgens or the cysts on the ovaries. But because she doesn't appear overweight, or she doesn't appear to match whatever idea they had in their head of what someone with PCOS is supposed to look like, then she doesn't even get to the diagnostic piece of it. And I've also seen it in the reverse, where a person may then appear to, for whatever the physician is expecting of PCOS, they may appear like that, or they may even have irregular cycles, or they may even have cysts on the ovaries, but their cycles are fine and there's no signs of androgen. So there are also practitioners who will then diagnose women with PCOS, kind of indiscriminately, if they have one of these things or whatever it is. Again, not looking at the criteria. So those are just, in case you're wondering, how would this play out? And so bring it back to those of you who have been in this situation, you've been in the doctor's office and this has happened to you, or you are a women's health practitioner and you're working with women. This provides some context for why so many of your clients may have either gone undiagnosed for long periods of time when they clearly meet these criteria, or why you may have clients who've been told they have PCOS, but when you actually look at the criteria that I laid out, you're kind of like, well, they have this diagnosis of PCOS, but when I look at their cycles, their cycles are actually regular, and they've never even had an ultrasound. So how do we know that they had, what was the idea here? And so from a practitioner standpoint, this information that they found in the study, it should guide you and provide you with that additional bit of information that just because a person has received a diagnosis doesn't necessarily mean that they meet the criteria. Sometimes it's worthwhile to ask, so when you say you were given this diagnosis, did they do an ultrasound? Did they do blood work? How was this diagnosis made? And you would be amazed at how many times women are saying, oh no, my doctor just said so based on da 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 da, but they never actually even had the testing so that we could get the firm diagnosis. So that's certainly one of the ways I've seen this play out. The study itself was conducted in response to patient concerns. That's one of the things the researchers mention in there. And as you can imagine, having a lack of practitioner knowledge about the diagnostic criteria could certainly lead to delays in having an accurate diagnosis. And research shows that it takes anywhere from 2 years or more for many women with PCOS to actually get a firm diagnosis. And this is often after having to go to multiple practitioners along the way. And so, certainly not as long as the delay that it takes for women to be diagnosed with endometriosis, given that the average is somewhere around 8 to 12 years. But it's still pretty significant that a diagnosis for PCOS can take 2 years or more after multiple visits. Given that it's such a common condition, the stats on PCOS, the prevalence are about 1 in 6, so 15% of women struggle with this condition. It's one of the most common issues, and it's certainly the most common cause of ovulatory infertility. And so it's interesting to think that it's such a common issue that women face, but it can take so long to diagnose. And so few practitioners are even aware of the diagnostic criteria that's currently being used. So certainly an issue there. As a women's health professional, you already know the value of tracking the menstrual cycle, but I'm guessing that you're not comfortable interpreting complex charts, weird mucus patterns, abnormal bleeding, or other similar situations. You're passionate about fertility awareness and want to use it in your practice, but you're just not sure where to start. That's where FAMM comes in. The next class of FAMM is just around the corner. Registration is now open for the Fertility Awareness Mastery Mentorship Program. Classes start on October 4th. By the time you finish your FAMM certification, you'll have the skills to confidently teach fertility awareness to your clients, interpret all kinds of complex charting scenarios, and you'll have the step-by-step protocols you need to help your clients improve their hormone and menstrual cycle health. Apply today at fertilityfriday.com/FAMMlive. And when you apply, we'll send you the details to join one of our upcoming information sessions. Transform your practice in 9 months. Head over to fertilityfriday.com/FAMMlive. That's fertilityfriday.com/FAMMlive. Now let's go ahead and jump back into today's episode. When they looked at some of the features associated with PCOS, so things like the menstrual cycle irregularity, acne, hirsutism, androgens, they did find that the majority recognized the clinical significance of these and that they were associated with PCOS. One of the things noted by the researchers, though, was that a pretty high proportion of the OBs and REs associated cysts on the ovaries with PCOS. So the way that they stated it in the study would make it sound like there is a fairly significant percentage of doctors who think that cysts on the ovaries themselves mean that the person has PCOS, like that one sign is enough for diagnosis. And so it's important to know, just in a general sense, that a certain percentage of women just have cysts on the ovaries. So a certain percentage of all women, if everyone was ultrasound right now, there's a certain percentage of women who just have cysts on their ovaries. So that's a feature that applies to a percentage of the general population, and it's not enough for diagnosis. And again, going back to the Rotterdam Criteria, it's 2 of the 3. So it's not ever sufficient just for the person to have cysts on the ovaries and then for that to be enough for diagnosis. So they said it was 68% of OBs and 35% of REs associated cysts on the ovaries with PCOS. So that's pretty high. That's almost 70%, 7 out of 10 OBs. There were also certain symptoms associated with PCOS that the physicians were less likely to be aware of than others. So most of the physicians were aware of the obesity issue and the importance of physical exercise to improve symptoms. But there are other risks associated with PCOS, including depression, issues with body image, reduced quality of life, and anxiety, as well as the physical issues of cardiometabolic problems, insulin resistance, etc. And they found that the physicians were not as likely to be aware of the anxiety piece of that. Unsurprisingly, the most common treatment that was offered or that the physicians were familiar with was hormonal birth control, especially for women who were not currently trying to conceive. And the patients, when they were surveyed, reported that fewer than half of the physicians gave them information about counseling or different types of medical management. And so the researchers basically said that their survey suggests a gap in knowledge related to the conditions that are associated with PCOS. And they felt that this could translate into inadequate information being provided to patients. So ultimately, what does this study tell us? I would say that it tells us that there's a fairly significant gap in the knowledge of PCOS diagnostic criteria, some of the associated symptoms, as well as treatment options among many physicians. What's concerning about this study, as I mentioned, is that it was not done just in general. This was not just all physicians like a pool. It was very specific to OBGYNs and reproductive endocrinologists, the ones who should know. And then, of course, the question that we have looming, because the study only looked at those particular groups, is what is the knowledge like among general practitioners, your average GP? And I feel that we have no reason to think that a general practitioner, someone who is not specialized in this specific area, would be more likely to be aware of these criteria than an OB or an RE. So I feel like this study has significant implications for women and also women's health practitioners, given that many of these doctors don't have a specialized knowledge of some of these very, very common conditions. This, again, could lead to many women with PCOS being undiagnosed. If the physicians themselves are not familiar with the most widely used and accepted diagnostic criteria, you're going to end up with a lot of women who aren't diagnosed. And because of the biases and misunderstandings around PCOS that are also apparent here, where if you're not really aware of the diagnostic criteria, then you're going to kind of throw in whatever you think is associated with the condition. And you might mistake some of the symptoms or some of the common attributes with the actual diagnostic criteria, and diagnose women with PCOS who don't even have it, which happens so frequently. And for example, in the FAMM program, well, we go through the PCOS unit and section, and we go through this information. I mean, one of the things that we're training our practitioners to do is to be able to help their clients identify. And so that means that we don't just take whatever for granted. If they come to us saying, okay, yes, I have this diagnosis, you just want to check in and say, okay, well, let's go over the criteria and make sure that the person actually meets the criteria. One other piece that came apparent in the study is that the reproductive endocrinologists were much more likely than the general OBGYNs to be aware of the specifics of this condition. So in all areas, they fared much better. So they fared much better in terms of having a higher percentage who did actually know the correct criteria to use. So although it's still low, it was still about 68% of REs who were aware of the diagnostic criteria that should be used. Only 41% of the OBs were aware of the criteria. So that means that if you're going to an RE, you're more likely to get the correct information, but it's still not as high as you would think it would be. You still wouldn't expect a full, 30% of over 30% of these practitioners to really not fully understand the criteria. So that's certainly concerning. I feel like a couple other things we can take from this study. One basic piece of information that I feel we all should be aware of as women who occasionally need to seek medical support. We cannot expect our doctors to know it all, especially when they don't specialize in the condition that we think we have. It's something that we really have to, I suppose, in my opinion, accept and really internalize. We have been trained, I think, from young to go to our doctors expecting that they do know everything. And we expect them to have all the answers. We expect them to be able to tell us what to do. And we want it to be easy. We want to go to their office and we want them to tell us what's wrong with us, give us the solutions, and we want to go home. But unfortunately, that's not the reality of the situation. So that's certainly a takeaway from the study, a reality check, an important one to remember that, and even highly specialized doctors who should know these things, we cannot expect them to know everything. After all, these doctors are also human beings. And I'm sure that when they're in medical school, they are thrown tons and tons of information about tons of conditions. And I think that it makes sense that at some point in each medical professional's career, they're specializing in a certain area or seeing certain conditions more than others. And so you certainly, when you're going to a physician, you always have to remember that they're not a computer hard drive or something. They do not know everything, and they certainly don't know everything about every condition. And I mean, that speaks to the importance of seeking support from someone who does specialize when you have a specific issue. I think another important takeaway from this study is that it does validate if you've had this type of experience, whether it's with PCOS specifically or not, or if you're thinking about experiences you've had with clients over the years. It's validating because it shows us why. I think that sometimes when we're hearing patient stories, or when you're hearing stories from your girlfriends, or even listening to the podcasts, go back to listen to some of those Pill Reality episodes, right? Or FAMM Reality episodes. When you hear these stories and you have women who they're describing their experience, they clearly meet the definition of whatever condition it is, or at least their symptoms are significant or severe enough that they should be screened, right? And you can just as a person listening to an interview, you can tell, you're kind of like, well, wow, if you have all these symptoms, like at least at bare minimum, you should be screened, right? It should flag someone's attention, particularly someone who spent many years in medical school, right? But studies like this show us, okay, this is why, and it's not in your head. It's not this imaginary thing or whatever. And it also shows us why it's so common for women's concerns to be dismissed, for women who have all of these symptoms who seem to warrant further investigation have not been investigated. And also why women are given the wrong diagnosis, like where they don't have the condition, but they're still getting a diagnosis. So I feel like studies like this help us to understand why this is happening. So this study was released in 2017. And I think it's interesting to see how the researchers wrapped it up in the end, in their conclusion. And of course, they acknowledge that an accurate diagnosis is important, I would say essential, to enable early interventions, right? And to help people. It's better when you get a diagnosis, because then you know what's going on and that can prompt you to get the care that you need. And so they're saying, okay, there were some limitations with our study. Of course, we didn't survey 60,000 people, right? They had a survey response rate. They had 630 of these physicians who responded. But it was the largest study to date on this particular topic, right? So at the time that they released it, this is the biggest study of physicians. And again, what I think is the strength of this study is that they didn't just go to general practitioners. They went directly to the OBs. And I think they would have themselves been surprised at the results, given that these practitioners that are so highly specialized didn't fare better in terms of their knowledge in this such a common condition for women. Ultimately, unfortunately, it is up to us to be our own advocate. It's up to us to seek out the care that we need. And especially for women's health practitioners, it's important for us to educate ourselves so we can be that advocate for our clients. Again, in the FAMM program, when I'm working with practitioners, I'm often reminding them that for many of their clients, you may be the only one who is using the menstrual cycle as a diagnostic, and to be able to help your client to identify some of these issues, again, that their doctors may not even be diagnosing, which may not even be on their radar. And as the study shows us, potentially the reason it's not on their radar is because they're not even aware of the most widely used diagnostic criteria. So I feel like that's a good place to stop today. I hope that you enjoyed today's episode, and please share it. If you can think of someone right now who would benefit from this episode, please do share it. And again, the share link is fertilityfriday.com/484. For other episodes in the FAMM Research Series, you can head over to fertilityfriday.com/research for the full list. And if you are a women's health practitioner, head over to fertilityfriday.com/FAMMLive, FAMMLIVE, for details about how you can start using the menstrual cycle as a diagnostic tool in your women's health practice. So with that said, I hope you have a wonderful weekend whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting. And that's a wrap. If you're loving the FAMM Research Series, then I know you'll love our Fertility Awareness Mastery Mentorship Program. It's a 9-month immersive experience that will completely transform the way you work with clients, allowing you to not only teach fertility awareness to your clients, but to use the menstrual cycle as a vital sign and diagnostic tool in your women's health practice. Our next class starts on October 4th, so there's still time to reserve your spot. Apply now at fertilityfriday.com/FAMMLive. When you apply, you'll have the opportunity to join one of our upcoming information sessions for additional details. There are no other programs like this offered anywhere. Transform your practice in 9 months. Head over to fertilityfriday.com/FAMMLive to apply now. That's fertilityfriday.com/FAMMLIVE.